my name's Chelsea. I'm going to go over a surprise malignant hyperthermia case with you today. So I have a 25-year-old female that came into the ER as a trauma for a motor vehicle accident. She has an open femur fracture. So our plan is to do a general anesthetic with a regional femoral block. She's 66 inches, 60 kilograms. The ER was nice enough to put in an A-line and a central line and a Foley catheter with a temp probe because she was a little hemodynamically unstable when she arrived. She has no other history, doesn't take any meds. She has an ASA 1E. I went into the ER and did an assessment on her. She has good airway. She is a thyroid mental distance of 3, Mallampati 1, good range of motion. I listened to her cardiac pulmonary. She sounds great. Her labs that have come back are normal. I went over risks, benefits, and indications. So the risks for general anesthesia being sore throat, nausea, vomiting, dental damage, risk of pneumonia or pulmonary aspiration, cardiac arrhythmias, recall, cardiac arrest, stroke, and death, which we will prevent by monitoring hemodynamics closely. The benefits of this is she's going to be asleep during the procedure. Regional, she is getting the femoral block, so risks bleeding, last, quad weakness, and then benefits is post-op pain relief. Hopefully can get her moving a little quicker. She did consent to this and we are ready to go. So I am actually going to do her femoral block in the ER. So I'm going to go to pick her up. Before that, I have gotten my room ready for a normal case. I have done my machine check. I have my suction working. I have all my airway supplies. My gases are full. I have my monitors. I have my emergency meds, and I have all my induction stuff ready to go. So we're gonna go do that femoral block. I have my nerve stimulator, my needle, my bupivacaine 1/4%. I'm going to give her 2 milligrams of Versed, 2 grams of Ancef if the ER hasn't already given her antibiotics, and I'm gonna give her 100 mics of fentanyl. Again, depending on what the ER has already given her. We're gonna place the block and then we will bring her into the OR. We're gonna move her over to the table and I'm going to hyperoxygenate. So just with oxygen, we're gonna hyperoxygenate 3 to 5 minutes. While this is going on, I'm gonna hook up all my monitors, get baseline vitals. I already have access, all those good things. So for my meds, I am going to do 120 of Prop, 60 of lidocaine, and then we're going to do 100 of Sux. So I have my patient all pre-oxygenated. They're in the sniffing position. I'm going to go ahead and give my propofol and lidocaine, make sure I can mask ventilate. Then I'm going to give my succinylcholine, and I am going to intubate. I did not anticipate any difficulty, so I'm going to use a MAC with a 6-0 tube. And I am going to verify placement by seeing mist in the tube, seeing an end tidal CO2, chest rise and fall. I'm going to listen, make sure I have bilateral breath sounds. As long as all that's good, I can secure my tube. And I am going to turn on my ventilator, turn on my gas. I'm using Sevo. We're at 6, we're gonna shoot for a MAC of 2. I am going to give any of my meds like the Zofran, Decadron, Reglan, all that in the maintenance phase. And we're just riding along, and halfway through the case, I noticed that our end tidal CO2 is creeping up. I've kind of tried to hyperventilate the patient. It's not really doing anything. Her temperature is rising. She feels really warm. She's starting to get rigid. The surgeon's making a comment. So first thing that's going through my head is MH, malignant hyperthermia. So I'm gonna notify the surgeon that this is what I'm thinking. I'm gonna call for help. And then everything's gonna kind of happen simultaneously. So first things is we want to get dantrolene into the patient within the first 10 minutes. So for that, it's a 2.5 milligram per kg dose in the MH cart that will be brought in when you call for help. There are vials that are 20 milligrams per vial. You mix it with sterile water, 60 cc's. And we would be giving for her 150 milligrams, so we would need 7.5 vials. So as you're doing everything else, you're gonna be just giving that dantrolene as your buddy hands it to you when it's ready. Other things we're gonna do is, first off, we're going to stop our gas, stop the triggering agent. We're gonna turn our fresh gas flow up to 10 to help flush that out. We're gonna change our tubing, put on charcoal filters. We're gonna change our CO2 absorber if all that is available. We're gonna hyperventilate at that 100%. We are going to be sending ABGs, giving bicarb for acidosis, checking our potassium levels from that muscle rigidity. And we are going to treat high potassium with insulin and D50. We are going to try to cool the patient, so ice packs, cooling blankets, cooling the fluids. We want to prevent any kidney damage from that myoglobin going into the kidneys and causing rhabdo. So we want to maintain urine output. We're going to hang a bag of fluids, run that wide open. We are going to support our hemodynamics as needed, support our blood pressure, which may be tachycardia, or our heart rate may be tachycardic, so we're going to support that, support our blood pressure, the acidosis, hyperkalemia. Make sure our patient is supported completely. We're already halfway through the case, so our surgeon is going to either get to a place where they can stop or quickly finish up. And then we're gonna plan to go to the ICU where they will be managed for the malignant hyperthermia and their post-op. So also at the beginning of starting this MH protocol, we still need to keep our patients sedated, so we are going to do a TIVA. With this patient, she already had a regional block, so we are going to put her on propofol, 100 to 120 mics per kg per hour, and just kind of titrate as needed for hemodynamics. We may need to add some fentanyl pushes, we may need to add Dex, just kind of feeling how she's responding while maintaining all of her other MH symptoms. So it's kind of a busy cluster going on, but you'll have help and hopefully be able to support this patient throughout this acute phase, get them a little more stabilized. You're going to transfer to the ICU where you're going to do handoff to the intensivist and the nurse there. You're going to let them know what happened, what you think your triggering agent was, any interventions for the acidosis, hyperkalemia that you may have done. You're going to talk about fluids, urine output, estimated blood loss, antibiotics, all the normal things that you would cover. And before you leave, you're going to look at your patient, make sure that they are in a safe place, that they are fairly stable, and ask your nurse if they have any questions, any comments, concerns, and then you are good to go set up for your next case.